Proud and privileged to be here. We know that diabetes, it is progressively increasing number of cases we see more and more. And as far as we go with the data, we find that at least there is a gap of 3 to 5 years before the person has been diagnosed diabetes. So from the onset of diabetes till the diagnosis, there is a gap of approximately 3 to 5 years as far as the ADA guideline says. So how we can bridge that gap, how we can diagnose it early, and how the early diagnosis can be helpful in treating this kind of patient. And I'm sure like if we can diagnose early, we can reduce the number of complications what are happening to diabetic patient over a period of time. And probably the tip of iceberg what we see, probably we can go to the base of that iceberg and we can be in a better mode to treat that. So to discuss on this topic, today we have a senior endocrinologist, Dr. S.K. Sharma from Jaipur, and we have Dr. I.P.S. Kochar from Delhi. So both these stalwarts in the field of endocrinology and diabetes will be discussing on this particular topic. So let us start the ball rolling with Dr. Sharma. So how often do you see the patient like probably who have new onset of diabetes, and looking at that patient, you feel that probably if this person would have come a bit early, I could have done many good things to this patient. So what is the frequency and how do you go about such kind of patient?
Well, if you see, half of our patients are not knowing that they are diabetic. So 50% of our diabetic patients are not having symptoms of diabetes. So they are detected incidentally. Incidentally means when they are going for some health checkup or some, you can say, employment, medical checkups, etc. Or they are going for example, cataract surgery or heart problem, and then they are undergoing diabetes evaluation also. And then they realize, oh, I am also having another problem of diabetes. So this is not uncommon. This is very, very common. And as your question pertains, as you rightly highlighted, large number of our patients are having very high HbA1c at the time of diagnosis, which indicates that probably they are having a very long duration of diabetes. Not only that, many a time we see the complications of diabetes in the form of some eye problem, retinopathy, background retinopathy will be there. They may have some loss of sensation in the feet, indicating that they have diabetic neuropathy also. And many of these patients are also having cardiovascular disease in the form of abdominal obesity, hypertension, dyslipidemia. So all these things are there in this patient, indicating that probably we missed the diagnosis for a long time. Many a times they give us a history that they are losing weight for the last, let's say 2 years, 3 years down the line, indicating that probably they have started diabetes 2-3 years back. Thank you.
Absolutely right. Like the weight loss is very, very important, probably sign or symptom. And I'm sure like Dr. Kochar, you would be dealing with more, I suppose, with a pediatric kind of a population. So there again, the weight loss is one of the very much concerned kind of a problem. But in your practice, how frequently you find such kind of patient where the diagnosis is delayed for whatsoever reason?
So I think, Dr. Swindle mentioned 50-50. I think it's a little more, maybe around 70-30 people percentage where they, awareness has become a little better, but 70% still do not know. They have, and they already come back. See, like, let's start with pediatric population. Pediatric population, most of them, they come, they already have, well-established diabetes. They know it's not picked up. They don't understand the signs of, what is, like if you start at infancy age, it's like if a patient is passing a lot of diapers are getting more wet as compared to that is what that means, that which is not known by most of the population. Number one is that. Number two, weight loss, as Dr. Swindle mentioned, it's a very, very common sense. Third is that, the behavioral changes or irritability. It's commonly seen in these patients, and it's a very early sign, many of the diabetic, but it's not picked up. So that's another sign which is commonly missed. Fourth is that, maybe some infection like vaginal infection or, maybe occur, especially in girls, may occur and that it's not picked up. Another very commonly, which you are missing, and most of the patients, besides the weight loss, is, their food appetite. So in the, like in adults, you have patients eating more and more. In the pediatric population, you can have both types. You can have patients who do not eat at all, or are very not very hungry, or patients who are very, very hungry. So this is also seen in the diabetic population, in the pediatric and adolescent, especially in the young population. Then sixth is, they may be, besides this, many of these kids they have they may say that, they are very lethargic, they're very fatigued, they were doing something, playing some game, they're not able to play those games now, that the fatigueness is becoming more and more. So people think that isko khana nahi khaya, अच्छा था इसको खाना खाया, 2 दिन से सोया नहीं होगा इसलिए हो गया. That type of thinking coming up. So it's always getting delayed and delayed because they never think along this line. Then there may be a possibility, adolescents, they may get headache, they may get dizziness, they may, even in the adult population, these things are also like, at thirst and hunger, eating more, headache, dizziness, and many commonly blurring of vision. So it's, you can find in any other population, if somebody complains of headache, blurring of vision. So first thing everybody thinks is blood pressure, iska check karo, blood pressure, hypertension, maybe hypertension. So get to check your blood pressure, but nobody thinks in terms of diabetes. That diabetes, one of the symptoms is blurring of vision, and this, can occur headaches and occur. So that is because there is edema and there's collection of fluid in the lens, and then it comes with this. So these are some of the things which I think the physicians have to wear, and we have to make more awareness in the public about it. That this is some things which you have to remember. These are some of the signs, or some of the symptoms which the patients with diabetes can have in various population, elderly and the pediatric population, adolescent population. So with that, I think that's how we should look at it from this point of view. So this awareness has to be made more and more, and that's why most of the patients, if you talk about the pediatric population, they all come. Very few of them, because if their family someone is having diabetes, then if they get some excessive urination or if they get sepsis, then they said, okay, बच्चे का टेस्ट करा जाता है कि इसको डायबिटीज तो नहीं है, so that's picked up early. But otherwise, most of the time they say that AC, because in the AC it's in summer, that's why it passes more urine. Or if very, very important, bedwetting. Normal child who was passing normal urine starts bedwetting, think of diabetes. So this is another, seen in pediatric population. I have adult patients also a lot, but I think in adult population, most of them are coming late. There is awareness being created now more and more about it. But compared to 10 years back, I think awareness has become better, and people have started realizing that if I'm putting on weight, or if I'm losing weight, or if I'm getting a lot of urine, or if I'm eating more, or if I'm very thirsty, or mouth remains dry for a long time, think of diabetes. So I think these things are, important from the pediatric population and the adult population.
Absolutely. Because unless we understand the symptoms and we remember these symptoms, probably we are not going to take a test. Like as Dr. Sharma said, like incidentally, they're going for a pre-op workup and you find diabetes, or some pre-employment workup, you find them to be diabetic. So now again, like if there's a family history of diabetes, so do you think that a family history of diabetes will make an early diagnosis because they know that their father or mother or somebody has diabetes, they had some XYZ kind of a symptom, and so probably if their child has those kind of symptoms, do you think that the diagnosis will become little easier for parent, or it becomes easier for them to take to doctor? So what in your current scenario you find in such kind of cases?
Well,
This question is to whom?
Dr. Sharma.
Okay.
So family history in diabetes is very, very important, because we see that type 2 diabetes, many times patients are having strong family history. Either mother, father, or sometimes both parents are suffering from diabetes. So if the family is having high incidence of diabetes in the family member, then if the patient develops some symptoms, probably we think that they will be getting early diagnosis. But even in this type of patients, sometimes we see that they don't think that they will develop diabetes. So there is a, you can say, false sense of well-being that how I will develop diabetes. I can't develop diabetes, something that is there. So you have to remove that sense of false, you can say, sense of well-being that I can't develop diabetes. So if the strong family history is there, if the patients are having obesity, for example, that person is significantly obese, he is having very lack of physical activity. Now, stress is also a very important risk factor for diabetes, hypertension, and cardiovascular disease. ladies who had a history of gestational diabetes in the past, or a lady who is suffering from polycystic ovarian disease. And then there are persons who are having hypertension, dyslipidemia. They are again more prone for the development of diabetes. So these are the group of patients who should be having this knowledge that they should undergo frequent checking of their blood glucose profile. So recommendations are that if these are high risk population, they should undergo a yearly screening. If the risk is less and the age is more than 40, then at least 3 yearly screening should be done in this type of population. Thank you.
Thank you, Dr. Sharma. Dr. Kochar, like in pediatric or in a young population, adolescent population. So again, do you think the same thing stands true for your adolescent population as well? Like if there's a family history, diagnosis could be a bit easy for parents to diagnose it?
Yeah, I think it's a good question because, in the population, its awareness has become more because of this reason only. इसके father को diabetes है. So let's talk about a younger population. His father को diabetes है, this thing. So if they find the child, but there's something that they don't pick up. They don't pick up. That if the child is passing urine bedwetting, they don't pick it up. If the child is not, is having some dizziness, or child is, irritable, they don't pick it up. But if the child passes, polyuria is there, or polydipsia is there, or polyphagia is there, or patient losing weight, they start thinking that, okay, maybe he's diabetic, maybe because we have someone in the family. So that awareness is slightly better in that population as compared to the parents in the population where there is no, no awareness. So those kids, they all come with DKA, most of them, because nobody knows in the family. So they go to the doctor also never checks sugar, he'll just say, oh, fever ho gaya, maybe he's having some other, they do all X, Y, Z. And then by the time the ketones are developed, so that is their stage. Now coming on to adolescent population, they are both type 1 and type 2 diabetes, both are there. So we have a lot of adolescents with type 2 diabetes now. And it's just like adults, starting with drugs now. So there also, I think like Dr. Sharma mentioned, that patients who are with PCOS, patients with family history of diabetes, patients with, with hypertension, the children with, having a lot of obesity, vacanthus nigrans. So in those population and family history, strong family history of diabetes, one starts thinking in terms of, having that they know that these things, although they will not know, unless they're very, very educated about this PCOS and all that, they will think that, still they will think that maybe you cannot have it. It's very common, like Dr. Sharma said, that, patient comes to you, father says that, but how did my son or my child get it? It's not possible. He's still he's just only 18 years, 17 years old. How can he have diabetes? I think, doctor, your diagnosis is wrong. So they'll go to another doctor, and keep on trying to see, to get out this in the mind that he does not have diabetes. Then finally, when everybody says, then they say, okay, oh yeah, you're right, he had diabetes. So that, awareness is has to be more and more there. And second is that, that as if you compare only with the patients who have a family history of diabetes, still they don't agree very fast, but they're aware of it. At least they're going to the doctor to check and find out about it. That definitely makes a difference if the family history is there versus non-family history.
Thank you, Dr. Kochar. Excellent guidance. We have Dr. Subodh Bansal has also joined. Dr. Subodh Bansal is a professor in Indore and is a senior endocrinologist from Indore. So, Dr. Bansal, we have been discussing diagnosis of diabetes early stage. So, in your practice, if a patient is coming, say, for thyroid or for obesity or for some other illness, so how frequently do you ask their blood sugar test to be done just to be on a high cautious that he can develop diabetes or he is at risk of diabetes or he is a potential candidate for diabetes? So do you visit on every visit or every 6 months or every year if a person is visiting to you every month? So what would be the kind of frequency to get their sugar test though they are not diabetic as of now?
I think all autoimmune problems, those who have maybe related to thyroid, obesity, even the young people at the age of 20, if they are obese, I get their blood sugar done now. We call it another sort of vital it has become. So sugar doing in clinic is a routine. I said, this is what I do in almost all patients. either male, female, the female coming for something else, we want to check it. If she's becoming, going for pregnancy, we should see that if she's not a diabetic or she has impaired glucose tolerance. So irrespective of this thing, but naturally those who have family history, given birth to a big baby, having acanthosis nigricans, having obesity, thyroid related disorders, I think this is very, very important that we should try. And in our country, well, Dr. Sharma was talking about 40 years of age, even at the age of 25, because we get earlier, 1 decade earlier than the Western population. So we should try to see that, especially if family stays there and a patient is father, mother, and acanthosis nigricans, and the child is quite obese. I think that's what we see it. So type 2 diabetes is not that uncommon. Rightly said by Dr. Kochhar, type 1 naturally presents like this, having polyuria, polydipsia, loss of weight, and other things. But in type 2, you never know what it remains asymptomatic most of the time. Unless the sugars are very high, then they develop osmotic symptoms, maybe polys or loss of weight. That is a different story. But in most of the type 2 diabetes, they remain asymptomatic. We should have high index of suspicion, and we should try to just monitor or screen them for sugar. If it is normal 80, 90 random, forget about it. It's coming 200 or more than 40, 150, I always tell them to just recheck it and confirm if they have diabetic. Over to you, Dr. Arya, please.
Thank you, Dr. Banjal. So we understand over here that surveillance is very, very important, that as and when you come in contact with the patient, always take a blood sugar test, at least those who are at high risk for developing diabetes. So that can be one of the modality to diagnose it early.
Absolutely.
And
Yes.
Dr. Sharma, yeah. Dr. Sharma, like in a newly diagnosed diabetic or in an early diabetic kind of a patient, what we are seeing, they are presenting to us for the first time and they have diabetes. So what is the kind of frequency of micro or macrovascular complications on their presentation in newly detected diabetic patients?
Yeah, very important, because as we are discussing delay in the diagnosis of diabetes, particularly type 2 diabetic patient. In type 1 diabetic patient, things are a bit more dramatic. Within a period of few days and weeks, patient is significantly symptomatic, polyuria, polydipsia, polyphagia, and weight loss, and Dr. Kochhar highlighted bedwetting, etc. But in type 2 diabetes, there is a very long duration of asymptomatic phase, and during that phase patients are not aware and they are coming to us after very long time. And here I want to say that 20 to 25% of patients in the general medical OPD, when they are above the age of 30, they are having diabetes. So diagnosis of diabetes should be early. So we should have high index of suspicion. And as Dr. Banjal highlighted, that he is doing sugar profile of most of his patient is also a right approach in Indian context, because we are the capital of diabetes in the world. Now, looking into complications, patient is coming diagnosed first time as type 2 diabetes, and 5 to 10% of these patients are having microvascular complication like background retinopathy, some sensation loss in the feet, or absence of reflexes in the feet. And there are some patients who are adult giving history of erectile dysfunction, and simultaneously they are having some proteinuria, that is nephropathy indication, some rise in blood pressure. They say that I was having normal blood pressure 6 months back, but now blood pressure is rising. And some may be having some investigation like lipid profile, and it is showing abnormal high lipid, you can say cholesterol, etc., and triglycerides. So it is not uncommon for us to see complications at the time of first time diagnosed patients. And what it indicates that diagnosis was significantly delayed, because we know that these complications are usually occurring something like 5 years of uncontrolled hyperglycemia. That's why we say that at least they are delayed by 5 years. Thank you.
Thank you, Dr. Sharma. Dr. Kochhar, like in adolescent population as well, like who have say type 2 diabetes, they are adolescent, and they have some complication at the time of diagnosis as well.
I would not say that they have complications, but as we have been studying and on, we find, some of them may have some involvement of a little bit of retinopathy and nephropathy. That's not very common because, it takes at least 5 years of on this to occur. So I think maybe, the adolescents are coming earlier because of, this awareness of acanthus nigrans, obesity, dyslipidemia. These things are very commonly seen in the adolescent type 2 diabetes also. So it's not that it's just in adults. So once you get type 2 diabetes, that means insulin resistance is occurring and therefore the insulin is not able to work, and then you have this picture. It's most of our type 2 diabetes adolescents are obese. We very rarely have seen lean, thin type 2 diabetes. So most of them are obese. Obesity is one of the big factors, and most of them that, as I told you, family history, mother and father are obese, child is obese, having cancer migrants, having dyslipidemia, having all these features. So these are all risk factors. I will not say that complications because dyslipidemia is a risk factor, hypertension is a risk factor, all these are risk factors, we see. But as you know, there are not many studies to say that, we know that diabetics are having 2 to 4 times adults. There are 2 to 4 times to get more cardiovascular risk as compared, to non-diabetic. But there are not many studies in type 2 diabetic adolescents which to say that how much, already got cardiovascular risk or already having some cardiovascular issues. So it's very, very, because I was screening my diabetics, with retina and with, with urine protein, everything. So very few. So that's why I think there's still a lot of studies, a lot of literature because there's very few young study was there in diabetes. So they have more study have to come to see how many of these percent of these people of type 2 diabetic adolescents are getting retinopathy or nephropathy or neuropathy, any of these complications, on the onset. Or it is possible that maybe in the type 2 adolescents, they don't come, like they take 5 years to become the onset. So they may be coming a little earlier as compared to the adult population. And then, when you don't get all these, nephropathy, neuropathy, they come with a complaint is most of the time they'll come either they're losing little weight because they were initial this weight, now it is this weight, or they will say that they're getting hungry, they're getting more and eating more and more and more. And with all these, they will come with a black neck. The neck is becoming black, the neck is going black, the neck is going black. This is a common they come with it. And when you check the sugar, you find that they have impaired glucose tolerance or they have, diabetes already started. Many of them will come and tell them. If you go OGTD in these patients, will become many of the patients with, having impaired glucose tolerance. So therefore, that's how it is. But as far as complications are concerned, I think we need more studies to say that the percentage of population when they started, honestly, they're getting this.
Thank you, Dr. Kocher. Dr. Bansal, we have this kind of patients like they present type 2 diabetic patient and they have one or the other complication, and the number seems to be varying from 8% to almost 20-25%. At the time of diagnosis, they have micro or macrovascular complication. So in your routine practice, what do you think, like any patient who is stepping into your clinic, newly diagnosed diabetic, would you like to go for all those tests, like battery of tests to be done to look for all these complications for neuropathy, for their microvascular fundus and the renal and all those complications in the first go, or you will wait for some time and then you will send them for this workup?
Ideally, full workup should be done in all type 2 patients, because as I told you, they are most of the time asymptomatic. They are not sure, you are not sure for how long they have diabetes. Now we do the A1C and they say 10 है 11 है, then you may be having, say, 3 महीने का ही है, but you never know, 3 महीने के 3 साल या 6 साल, that is there. So ideally they should do, but practically it may not be possible. The day one patient comes at and you do all battery of tests, they say, why you are doing, I am okay. Even the ECG people will refuse. So, but we know the microvascular complications, macrovascular complications in type 2 diabetes, that day one should screen. And in type 1 diabetes, after 5 years, they should be screened for mitral, maybe for neuropathy, for retinopathy. And in the patients who are coming after the age of 35, 40 obese, I try to get even the echo done, because we know after all these new SGLT2 inhibitors have come in, that diastolic dysfunction is quite common and they call it as a part of heart failure. Maybe, you may call it as a diabetologist or endocrinologist, but certainly as the cardiologists say that even, 2/3 of the patient, they have systolic or diastolic dysfunction. The clear-cut reduced ejection fraction was found only 5% in the studies. So your question, answer to your question is, ideally, yes, all type 2 patients should go for retinal checkup. They should have micral. We should check their fundus. And one more thing, which most of the people forget, and from the time we are having non-touch technique during COVID, so that has become a big problem. So dorsalis pedis and the posterior tibial artery should be palpated in all patients, because peripheral vascular disease is also important part of the complications. So that is there. So get the ECG done, get the peripheral pulses checked, get the sensations as well as the fundus to be checked. If it is there available, get the micral. At least I get routine, urine done, at least macroalbuminuria we rule out. If they have something, certainly we go for it. So I do agree with Dr. Vivek that we should check all type 2 diabetes for all complications, because studies have shown even the neuropathy can come in the impaired glucose tolerance phase. So 50% of the people, so it depends on what type you are seeing patient and what type of study you are doing. So I think the ideal time is the day patient comes, may not be day 1, maybe after 3 months the patient is under confidence, you can get it done. भैया lipid करवा लो, ECG देख लो, sensation हम ऐसे ही देख लेते, fundus देख लेते. That's what I keep telling, and they do agree with you. Over to you, Dr. Vivek, please.
Thank you, Dr. Bansal. We understand that all the workup should be done. Patient should at least be counseled if patient is not ready for getting all the tests done in the first go, but at least they should be counseled that these are the tests he will be requiring, because since he has diabetes and we don't know the actual date of onset of diabetes. So Dr. Sharma, like in a regular practice, we find like a lot of newly diagnosed diabetic patient coming with say neuropathy or with some erectile dysfunction kind of problem. So what probably like we can do so that they don't develop this complication, like other than early diagnosis, anything else in terms of treatment or in terms of guiding them, or what can be done so that we can curtail this kind of complication happening in a newly diagnosed diabetic patient?
Absolutely. This is a very important scenario that what is the aim of treatment of diabetics? We want that they should live a healthy life. They should not have symptomatology like polyuria, polydipsia, polyphagia, and we want to avoid complications. And complications, as we all know, are microvascular like retinopathy, nephropathy, and neuropathy, and macrovascular complication like coronary artery disease, cerebrovascular disease, as well as peripheral artery disease. So, and may I add one more thing, that now non-alcoholic fatty liver disease and steatohepatitis is also very, very common in our obese diabetic patients. And obstructive sleep apnea is also not uncommon. So looking into all these things, we have to provide a wholesome or multifactorial intervention. So we should not be glucose-centric, that we are only taking care of the glucose part, but we, in addition to good glucose control, early glucose control, and for that we may be using sometimes combinations of the drugs, oral drugs. Sometimes we use in combination because the baseline HbA1c is very high. But in addition to that, we look at their weight, we look at their tummy. They have abdominal obesity, so we require them to reduce this abdominal obesity. Then we look at their hypertension, blood pressure, and if it is high, we have to correct that also, because we know that hypertension also exacerbates so many microvascular complications, as well as a very important risk factor for the macrovascular complication. And of course, lipid abnormalities are also to be looked into, and smoking is another important part, or tobacco chewing, which we have to be looking into and advising patient against these things. So a wholesome approach where we say that A, B, C. A stands for A1C, that means you have a very good control of hyperglycemia. B stands for blood pressure control, and C stands for cholesterol control, or we say lipid control. And with that, lifestyle is very, very important, with addition of anti-diabetic drugs. Thank you.
Thank you, Dr. Sharma. Thank you. Dr. Kochar, like in a pediatric population, like the first and the foremost part in managing diabetes, like type 2 diabetes, is to take care of their lifestyle modification and their diet and everything. So in an adults and type 2 diabetic patient, how good is the lifestyle modification and the and how frequently this adolescent they follow the dietary advices which has been advised by doctor or dietitian?
So you see, type 2 diabetes in adolescents, the main thing is lifestyle. So, lifestyle management, we always try first 2 months, 3 months, try to explain to them lifestyle, cut down the calories, cut down, sweets, cut down, all the fatty things, try to take a more of a protein diet. Total calories should be restricted and avoid some, foods also which are very sweet. So keep on telling them, take a amount of chapatis to be taken also reduce. So the dietitian has a big role to play in this also. The dietitian also gives advice on these things. We also advise, we reinforce with the dietitian these things, tell them. And then some, I think, maybe if you take 100 kids, 100 adolescents, maybe out of that, 30 to 40 will follow, 50, 60, 70 won't follow. But they'll be cheating. Actually, they may tell the parents that, we are doing it. And then they may be going with their friends, having a pizza and all that. And that whole thing is gone back to the same square rate. So this is a very common scenario where you are trying your best with this thing lifestyle, and it most of the time doesn't work. There are a few, adolescents with type 2 diabetes who do it. I have few who have done very well. In fact, they have everything has gone back to normal. H1C is fine now. They paid glucose or whatever the initial diabetic situation has gone back. They reduce weight. They're doing well. They're maintaining their weight. They're maintaining their lifestyle. So they are doing well. But 70% of these patients do not follow the advice, and they will just tell you that we're doing. Even they will cheat you on the sugars. They'll bring some chart, like diary with you, and then show that their sugars are okay. Then you tell them show on the glucometer. When you do H1C, H1B 7.88. Is how you doing it? How come your sugar H1C is 8 and you say this 6? So I have in my clinic, I have on the spot H1C. So I tell them, okay, let's do H1C. So it's happening many times. They're all cheating. So they will tell you we've done this. They bring the blue sugar diaries and they'll show that sugar, the 135, 140, 120 is well maintained. It's within time and range, the sugars. So, but when you do H1C, it's coming 8 and 5. So I think that's a little, so then they start saying, I don't know, doctor, let me. So I said, next time you do it, I'll come to know whether you cheated me or not. So it did. That makes a little difference, but still, it's a very, very difficult. This population of adolescents are very, very, difficult to make them do things and make them this thing. And even the parents, they come and tell us, so we tried our best on it. So then this comes as a lifestyle, the lifestyle diet and this thing. Dietitian also playing role, parents also playing everybody. So then even their colleagues, I mean their peer group, you tell them that he has to avoid it. But the problem comes with the grandparents. The grandparents will tell कि उसने तो कुछ खाता ही नहीं, बच्चे को तुम खाने नहीं दे रहे, मैं, what are you not, you're not letting him eat, you're not letting him this thing, वो कमजोर हो गया, ये हो गया. So they will give something to him to eat when the parents are not there, because parents may be working or may not be working, maybe here and there. So I think that, whenever you advise, you have to get sure that the grandparents are also in the picture at that time. So they understand what's actually happening, what is the problem, what are the complications which can occur. That's come to lifestyle. Then as far as medication are concerned, yeah, we are adding metformin. I've used Genemet also in some of my patients. I've used metformin. I've used Lactosa, as a this thing, especially the these adolescents. And we published this also, this about the use of Benazol. So they have, got results. But the issue is that, because just medication without lifestyle is not going to work. So that's why in all guidelines, whether it's ADA guidelines, first thing is lifestyle, and then you talk about the drug, SGLT inhibitor, GLP-1 analog, whatever it is. So I think that reinforcement, every time they come, you have to tell them the lifestyle, you have to maintain your lifestyle, you have to do this, you have to follow this, all of this, and you give them the medicines, whatever, I just told you, SGLT, you can use metformin. Then there are very few drugs approved in this population, but I think gradually they're all going to come up now because they're going to have complications like any type 2 diabetic. So they will gradually get SGLT inhibitors and all that will be coming into the picture. But as far as, the falling or follow-up is okay, but you can't be sure in the follow-up what you have told they've done it or not. So when they come back to you, okay, sir, I've lost 2 kgs of weight. 2 kgs of weight, so it's a big thing for them. They lost 2 kgs. When they go back, they start gaining, and then they forget that 2 kgs they have lost. And they start putting back again the weight, and then so it's a very, very difficult population, the adolescent population, to deal, especially talking with lifestyle only. So this is, I think. So back to Dr. Ved.
Thank you, Dr. Kochar. Dr. Bansal, as an adult endocrinologist, we see a lot of type 2 diabetic patients. So in your routine practice, like what is the kind of adult population whom you advise therapeutic lifestyle modification, and what percentage of your patient would be like following that lifestyle modification, and how do you stimulate them to follow that, or how do you be after their life that they follow this lifestyle modification?
See, I always tell, see, initially patient comes and he wants to do everything. आप तो दवाई मत लिखो, मैं 1 घंटा घूमेगा, सारा खाना बंद कर देगा, and after 1 month, 2 months, you realize that nothing is happening. So that is always like that. So problem is those who wish to lose weight, and even after SGLT2 inhibitors, I have seen so many people, सब मेरी टमी गायब हो गई, घरवाली बोलती है कि आप तो कमजोर दिखते हो. So I started eating and I stopped this, SGLT2 inhibitor. That's a usual story. And I always tell my patients, many times there's a fight between husband and wife. Husband says कि मेरी माँ खाना अच्छा बनाती थी, तुम अच्छा नहीं बनाती हो. So that lifestyle is very, very difficult. Whatever, the food habits have come in childhood, they remain. And it is very, very difficult, though people are talking about on internet, intermittent fasting, loss of weight. There are few people, maybe 3%, 4%, maximum 5%, who really follow the diet. Otherwise, most of the time, people say, मैं तो कुछ खाता ही नहीं हूँ, and he puts on 8 kgs. From where the 8 kgs have come in? It means lifestyle is very, very important. How to deal with it is very, very difficult. Unless you have a real good counselor, and people are after him. And the people at home should also understand. I always tell adolescent, अगर अच्छे अच्छे गुलाब जामुन बना के फ्रिज में रखोगे and you feel कि लड़का नहीं खाएगा, then it is not possible. So whole family has to be learnt about the lifestyle, the disease management, as well as the importance of diet. That's very, very important. And both the things, they work. Diet as well as the exercise or physical activity. If both are not there, you keep increasing the doses of insulin or OHA. Many people, they put on weight, and many times they have the fluctuations in blood sugar. They go yo-yo, and defensive eating is also quite common in type 2 patient. So that's what I realize. So I do agree with lifestyle is very, very important. Carb counting is important, but how many people follow it? How much to follow it? That's a question. So that's what. Over to you, Dr. Arya. That's what my personal experiences. They say one is practical aspect and other is theoretical. Theoretically, I do agree. Carb counting, you do it properly, manage it. People, those who are eating 2 meals a day, if you try to shift them to 3 meals, they add extra calories and they put on more weight. So what I say always my patient, that okay, whatever lifestyle is going on, try to modify, and I'll try to modify my medications as per your lifestyle. That's what is there. Otherwise, it becomes very, very difficult many times to counsel them about diet as well as the therapy. Dr. Vivek, over to you now, please.
Dr. Vivek, can I just answer one small mistake?
Yeah, Dr. Kochar, good.
Yeah. So I think policing is very, very important, because we had a talk with some professors from USA. So they said that even USA, there's a very, very difficult situation to follow the lifestyle. It doesn't work at all. So they call it as policing. So if you have, people are policing them again and again, every month somebody follows them up, then it is still possible. But otherwise, it's very, 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 very difficult to make people follow the lifestyle.
Absolutely right, Dr. Kochar. Absolutely right. As we understand that lifestyle or a diet, it requires a lot of family support, because if one patient is diabetic in a family, probably everybody needs to be a bit cautious. So I would like to know from Dr. Sharma, what should be the kind of a family support in this newly diagnosed diabetic patient? How should the family react? How should the family support this newly diagnosed diabetic patient so that, that behavioral changes and the modification is much, much better and controllable in the house?
Absolutely. Very important, I should say, point. Family support is very, very important. We have seen that if the family is educated and family is supportive of the patient, then control of hyperglycemia, control of all other things will be very, very easy for the patient. For example, if you have a patient in the family who is suffering from diabetes, and everybody in in that patient's family modify the diet, because it is not possible that all other people are eating the usual way and that they expect that patient should behave. So family member has to modify their lifestyle also. For example, they earlier are very fond of fried food, but now since the family member is diabetic, so they will be stopping, and everybody is eating a non-fried food more commonly as compared to earlier practice. So it will be helpful in those patients, those family members also, that they will be having a healthy eating pattern. And similarly, family members are going for walking, for exercise, for lifestyle modification. So the patient will see that this is the usual way. I am not doing something extra for my diabetes. This is the usual healthy way whereby I will be healthy and my diabetes will be controlled. So family support is very, very important. Many a times psychological stress and family conflicts, etc., increases diabetic, you can say, profile, and rate of complications are very high in these patients. So in these patients, we say that you should have a good eating habit. You should sleep properly for 6 to 7 hours at least, and you are not stressed out. That is very important, and stress is reduced when the family members are supporting it. Thank you.
Thank you, Dr. Sharma. Like, I think the family support is one of the very, very important kind of thing which is probably needed. Dr. Kochar will be seeing a lot of adolescent patients, and this adolescents, they are very gadget friendly. So I would like to know from Dr. Kochar, like how these gadgets like Fitbit band, and then you have not many apps which are available, which will calculate your daily activity and so many other things. Even the food what you are eating, you can find out how many calories, what amount of carbs and fat, and all those apps are available. So in your population, adolescent population, which is more IT friendly, how frequently they are using it and utilizing it to control their diabetes?
So, Vivek, yeah, it's a very good question, because most of the adolescents are that IT savvy, in fact. So they're using these gadgets to calculate carb counting, especially all those patients who are taking insulin. They will be using that to carb counting. When it comes to taking medication or lifestyle, they will do no carb counting. They might do a total calories. They might use an app for doing total calories, and they might be using the app to find out what the sugars are in the body. And many of them, even use sensors. They use the sensors to find out what is the sugars going on in the body, the level of sugar. But the problem is that it's okay. They're doing this saying, they're taking the sugar. They're trying to modify the diet. They're trying to decrease the calories at the time. But effectively, it is not very, very working out well, because they still are eating. So what they do is that, sir, हमारा आज वो था, हमने चेक किया था कि शुगर तो ठीक आ रहे थे, दूसरा ये था कि हमने कैलोरीज हमने एक्सचेंज कर लिया, हमने सो दे हमने एक्सचेंज कर लिया, हमने सोचा कि 2 रोटी कम कर लिए तो 1 पिज्जा खा लिया, तो दैट इज वो बात एक ही हो जाएगी. बट व्हेन दे गेट द शुगर, इट्स कम डाउन. So they are it is making some difference in some populations. The kids are doing very well. In fact, they're very this thing, and they're using these gadgets to understand the calories, to understand the carbs, to understand the sugars, and then they are doing it, and they're doing very well. So they will, monitor their sugar. They will keep the count. They'll keep a record of this, how much walk they have done, keep everything, and they'll come and show me. Sometimes I also don't understand the gadget, and then I tell them no, I'm just frankly telling you. So I tell them to explain it to me about it also then. So it's like that, so it's a little good. Its concept is good. It's good into the picture. But as far as when it comes to, using it from the point of therapy point of view, it's still, you can say, in the early phases. So, but many of these people use it, many of those. Even the type 1 diabetics kids, 10 years, 12 years, 14 years, they all are using these gadgets. They'll keep it on, and then they'll keep on checking the sugar, and they'll come to you with all the graphs of all the sugar. This is my sugar, this is my this thing. And now you see I'm doing well, so I should be able to cheat sometime. Like Dr. Sharma was, Dr. Subodh was saying that Indians are very fond of foodie. They आज मौका मिला तो आज वो खा ही सकते हैं रसगुल्ला गुलाब जामुन, because we are doing very well. So I think that is there. So in some way it is helping, in some way it is also, maybe not that good, because they know that they are getting these things good now, so they can make it, use cheat it also. So there are definitely, this picture is there. So I think you can say some of the policy, if the family involvement is there with these kids who are using the gadgets, the results are very, very good. If the family involvement is not there, especially the grandparents and the others, जो कहेंगे बच्चा कमजोर हो रहा है, बच्चे को खाने नहीं दे रहे, बच्चे को ऐसे ही मर जाएगा, बिना खाए भूखा ही मर जाएगा. So there, the results are, even if using the gadgets, is not that good. So this is what I have to, give the message.
Thank you, Dr. Kochar. Excellent point made. Can we have Dr. Subodh Bansal?
Yeah, go ahead.
Diagnosed diabetic patient who has been diagnosed recently, and he has been following like a bit of advice. At what point of time you will go into the depth and you will start discussing with the patient in more depth, like carb counting or glycemic index of a particular food? Will it be in the beginning, or will be after 3 months, 6 months, or once he has started developing complication or is requiring insulin? At that point, you will go into that depth and we'll discuss this kind of point with the patient.
That should be not too early and should not be too late. So complications come in, then what is the use of your consultation giving to the patient? So that is out of question. But if you start bombarding with all knowledge and everything from the day one, patient will say कि मेरे को समझ में नहीं आता क्या बोला. So first thing is try to pacify the anxiety of the patient. Try to control blood sugars with whatever way, with OHA or insulin or basal, whatever it is. And then later on, certainly, one can maybe after 2 months, 3 months, patient understand, they start talking about कि sugar इतनी है, क्या करूं, खाना इतना खाया. That is the time. Otherwise, the day one I have told भैया शक्कर और मिठाई नहीं खानी, तली चीजें कम से कम खानी और आधा घंटा 5 घंटा घूमना है. Very simple advice. And whatever, अगर पार्टी में भी जाते हो तो आजकल कोई खाने को पूछता नहीं. All buffets are there. You choose whatever you feel like. That's there. कोई पंगत में बैठ के कोई लड्डू खिलाने वाला कोई नहीं है. So I know I talk to them very simple language, and this is what I do initially. But later on, as the patient understands the sugars are there and they come back with bit better, A1C, then I tell them that this is the exchange and go for the low glycemic index foods which have more fiber, which are get absorbed little. Don't go for the sweets and other things. Even if you wish to have sweet, you can have little, maybe after meals. So that is there, the glycemic index will come down. So this is what I talk to them. So we have to be very, very practical talking to the patient. It is not that we are not mechanics, that 1, 2, 3, 4 and baar jao. So that cannot be done because we are not sitting in America. We have to understand patient psychology, their finances, their intellectual, and their family members also. If wife is sitting, it becomes easier to tell, and I try to send them to my dietitian also. And there are dietitians who really have, yesterday one patient came, sir, आपका भी वजन बढ़ रहा है, मेरा वजन कब हो रहा था, बढ़ रहा था, तो 10 किलो मैंने कम किया, भैया कैसे कम किया? So I have a dietitian sitting somewhere in, Maharashtra, and she gives every 1 hour, 2 hours WhatsApp, photo भेजो, क्या खाया, क्या नहीं खाया, अदरक की चाय पी, and what type of things. So this is what the dietitian is important. If the counseling is there and patient has to be motivated, if it is so, that certainly things change. So answer to your question is, don't bombard with knowledge the day one and don't delay too much. Otherwise, there's no point in your giving advice to the patient. Once the complications have come in, what is the use of giving consultation? So over to you, Dr. Vivek, please go ahead.
Thank you, Dr. Bansal. Thank you. Dr. Sharma, like 80% of our type 2 diabetic patients are obese. So at what point of time, like you will start not looking at sugar, but looking at his weight? Like in the beginning, you will target weight and not sugar, or how you are going to deal with the weight and the sugar both? Which will be the first priority and which will be the second priority, and how we are going to do it?
Well, obesity is one of the very important cause of diabetes, and not only diabetes but hypertension and dyslipidemia also, and that lead to cardiovascular disease. So right at the start of our therapy, we have to emphasize that you have to reduce weight also. So many a times we give them a very good scenario that, for example, a young boy is coming who is 30 years of age and he is obese and he's sluggish and he's not doing good activity and found of you can say he's foodie, then we say that if you reduce your weight by 10 kg, he is 100 kg at present, then probably you will be having reversal of diabetes. So that is a very important concept, that reducing weight will lead to you can say significant improvement in diabetes, hypertension and dyslipidemia, and it will improve physical activity, will improve the good cholesterol, and the chances of developing cardiovascular disease will be significantly retarded. So weight reduction is one of the very important pillar, I should say, in these obese patients, and we always emphasize that there will be either reversal of diabetes, or at least you will require very little amount of anti-diabetic drugs and you will get very good response with those little amount of anti-diabetic drug with your lifestyle and physical activity. Thank you.
Thank you, Dr. Sharma. You have brought a very good point of diabetic reversal. And probably nowadays everybody comes to the clinic and they want that give some medicine that will reverse my diabetes and I don't have to take all this medicine. There's no stamp of diabetes on my, I can eat each and everything. But again, I think it's a very, very difficult. Not everybody could be part of this remission program. And particularly, Dr. Kochar, in your practice where adolescents are there and probably their parent would be forcing you to give something where it can be reversed because the child has to get married and they have to have kids and all those kind of situations where they don't want the child or a girl to be diabetic. So what is a kind of a reversal or a remission kind of a burden on your practice, and how do you deal with such kind of a remission program?
So if we talk in terms of, type 1 diabetes, nothing is there. So there's no remission program. We just tell them you have to take insulin, you have to take insulin, you have to take insulin. You remove your lifestyle, you make a difference. The doses may become less, but you cannot be off it. So there's another group called as large, LADC now of the young, not the young population, but the childhood. So that group, the doses become less of insulin, but it is not. So coming on to type 2 diabetes, yes. So what we do is we have got, in fact, patients with remission also in type 2 diabetes with obesity. So the obesity is a factor we target immediately when you pick up type 2 diabetics. So in that we tell them you have to lose weight. We tell them all these things at the same time. कि तुम्हारा बच्चे का फैटी लिवर हो गया, तुम्हारे बच्चे कोलेस्ट्रॉल बढ़ गया, तुम्हारे बच्चे ये हो गया, ये कॉम्प्लिकेशन हो सकती है आगे जाकर. So all these complications of your micropathy, your neuropathy, and your retinopathy, and there's cardiovascular and cerebrovascular and perivascular, all this can occur. This is a time to stop all these things. If you do it in a proper way, it will stop. If you do not, you'll land up with all these things. So many of the population, they understand, not the parent, adolescent itself. Because, the adolescents like 16, 17 adolescents, they will not, even many times they don't want the parents to interfere. So they said that we are enough to understand, enough to do it ourselves. So when you make them aware of this, that this is going to happen, so they're interested. Okay, is it possible to remission also? So we were told diabetes cannot be admitted. So I think that, that trial which has shown that Dr. I think Roy, or I don't remember his name, that he has shown that patient remission, how it is possible. So therefore, we are making a point that they lose weight. Now, losing weight, will not occur only with lifestyle. You need to add some that. Maybe you need to add orlistat, maybe you need to add, liraglutide to make them lose weight. So when they lose weight, they're definitely, the sugars become better. Their, H1C cells become better. They also feel better. So then they see, and there are some kids, who have done very, very well, and touch wood till today, they are doing well. I mean, H1C is fine, that they're off drugs. But yes, lifestyle they're maintaining. Because, we know diabetes, we all have been studying type 2 diabetes is a, disease which is a progressive disease. We never heard in the past that remission can occur. So this is something new which is coming, and this is actually happening. So maybe they say that there's the pancreatic beta cells, there's a de-differentiation which occurs. So when you lose weight, the de-differentiation goes back to normal. So as a result of which, they go into remission. So there's a lot of this, theories coming up on this. So I think these kids who have gone into remission are maintaining remission and they're doing well. So I have a boy of 8 years who I'm following up for the last 8 years. He's doing well. He's in Canada now. So from there, he keeps on every 3 months, 6 months, giving me messages that this is what happened. So I think, this is what is there. But if I take a population of 100 adolescent type 2 diabetes, maybe, 20, which is, who have really followed lifestyle, who have lost weight and this thing have been able to maintain remission. Out of that 20, maybe 5, the 15 are going back to the same. So total out of 195 is back to the picture and 5 only on remission, you can say. So it's a very less percentage, but we always give them a try. We always try to help them in this way, that it is possible to do remission because you are 18 years, you are 17 years, you are 20 years old. You can do it if you do it properly, and this is the thing, and you are not landed to complications. So it makes a difference that if somebody in the family has had diabetic foot, or somebody has amputation, or somebody has cardiovascular, the kids are very worried. My dada had it, my nana had it, my this one had it. So they really want to do it. So they are motivated. So like Dr. Subodh was saying, it's a motivation makes a difference. So then they understand carb counting, they understand calories, they understand everything, and then they follow it. So I think, in the first go only, we always tell our patients that obesity ko kam karo, you will definitely get results. Back to Rob.
Thank you, Dr. Kochar. We may have because time is running quite fast, one comment from Dr. Subodh Bansal about, there was a bit of study about giving pancreas rest. By giving insulin, you give rest to the pancreas so that you can remit the diabetes or it goes into remission. So have you tried in some of your patients by giving insulin early enough and they go into remission, and how practical it is to do it?
I think it is important. See, there is a type 1 diabetes, no question. 1.5 diabetes, LADA, you give rest, things improve. And this study was done in 90s, 95, 98, we have this, 3 groups they have taken. And practically, if we see now, we know it is a glucotoxicity, we know it is a lipotoxicity. Once you reduce the plasma glucose level by any means, OHA usually do not work initially once the sugar is 500, 600. And I have many patients who were given basal insulin. You bring down the plasma glucose level and things improve. And after 3 months, 6 months, they are on 1 or 2 tablets. So it is not only my experience, other colleagues also have, you might be having the same experience. So if the patient has high blood sugar, it is not better. It is always better to give them insulin, give rest to the pancreatic beta cells, and they may regenerate again, or they may start, they may revert back to the original form when they start secreting. So giving rest to the pancreas by giving early insulinization, it is always better. And many times, even the adolescent people, they come and we give them insulin and they go in and they are control on OHA and SGLT2 inhibitors. So that is there. So I do agree, insulin works well. It is mainly because of the glucotoxicity. One has to reduce it. Lipotoxicity goes down. They have to control their diet as well as lifestyle, and it works well. Maybe they always say कि एक बार चालू किया, lifelong. I always say reduce the sugar levels and see how it goes. Maybe after 3 months, 4 months, you may need, and there are many people who do not really need, may not be lifelong. Maybe another 3 months or 3 years, 4 years, they go on OHs and they may need it, because those who have 500 plasma glucose level, usually they have not only insulin resistance, insulinopenia or insulin deficiency is there, but glucose oxygen reducing helps them a lot. That's what I would like to say. Over to you, Dr. Adia, please.
Thank you, Dr. Bansal. I think we have finished our 1 hour. So it was a wonderful discussion. And at the end of I would like to just sum up today's discussion that diabetes incidence is pretty high, the newly diagnosed diabetic. So we require surveillance to be on a good modality to diagnose it early. And again, the lifestyle modification plays a very, very important role. There are multiple medications are there. There are ways for remission or which again we should look into it and try to help. And again, the weight part to be taken care. The person who is overweight should reduce weight. So I thank you, Dr. S.K. Sharma, Dr. IPS Kochar, and Dr. Subodh Bansal. Thank you very much.
Thank you, Dr. Vivek. Nicely conducted and nice to see Dr. Kochar and Dr. Sharma. Have a nice
Okay,
day.
nice.
Thank you.
Yeah,
Bye-bye.
thank you everyone for
Thank you.
joining in. It was
Thank
nice, conducted. Thank you, Dr. Sharma and
Thank
Dr.
you.
Subodh, for
Bye-bye.
and meeting you and talking to you also.
Thank you.
Okay,
Bye-bye.
bye
Have a nice
bye
day.
bye bye
Thank you.
bye.
Can we leave?